So without further ado, I'd like to introduce Rajendra, one of the R's, an associate professor of ophthalmology at the Ophthalmology Institute, where he's part of the Vitreal Retinal Service. He's also director of the FEI's Population Vision Health Initiative, helping to improve eye health outcomes in our region and beyond. This work spans a wide range of issues and is highlighted by in-person and remote diabetic eye care and children's eye health. His efforts have been funded on the regional level and by the National Institutes of Health. His research has been reported in numerous peer-reviewed publications and he is widely recognized as an expert in population health worldwide. Rajiv studied medicine at the University of Rochester and then completed his ophthalmology and residency at Duke. He then returned to Rochester to complete his vitreal retinal fellowship at the Ophthalmology Institute and subsequently joined the faculty. As a member of the Eye Institute, he went on to complete his MBA at the Simon School. He's also served on various leadership roles, both nationally and internationally, such as Prevent Blindness, and is executive committee chair of Vision 2020 USA. He's here today to moderate the first session of the 69th Rochester Ophthalmology Conference. Dr. Ramchandran, take it away.
Thank you to Dr. Shafura. Next up, we have my good friend who's come all the way from India to help us out here. And this week at the Ophthalmology Institute, Dr. Narayanan is a world-renowned retina specialist who comes to us from the LB Prasad Eye Institute in Hyderabad, India. He is a leader in treatment of retinal diseases and a driving force in translational research. He served as director of retina services at LB Prasad, where he has advanced innovative approaches to care and clinical trials. His recent work focuses on cutting-edge regenerative therapies, including groundbreaking efforts to address geographic atrophy and dry macular degeneration, which is one of the key areas of necessary treatment in a blinding disease. After completing his basic medical education from Delhi University, Dr. Narayanan did his Master of Surgery in Ophthalmology from Guru Nanak Eye Center in New Delhi. He underwent a preceptorship in uveitis, ocular immunology, and at the Uveitis Service, Massachusetts Eye and Ear Infirmary. He then completed clinical and research fellowships in retina at UC Irvine before joining LB Prasad. He has authored more than 200 journal articles, book chapters, and abstracts, and is editor-in-chief and co-founder of the I Hope Journal of Ophthalmology, which is a leading journal in public health ophthalmology in India. As an educator, he has mentored more than 75 retina specialists, and we look forward to his contributions to the residency and fellowship and the director of retina services here at the Ophthalmology Institute. We're thrilled to have him come and share his insights about the results of a phase 1 clinical trial for RP stem cell therapy and the treatment of dry AMD. I welcome Dr. Narayanan to come and deliver his talk.
Good morning, everyone. Thank you so much, Rajiv, for the kind introduction. It's a pleasure to be here, coming all the way from India, relocating here, but I'd like to spend a couple of minutes thanking the people here for being so kind and generous, supporting my move here, especially Dave and everyone here at Plum. It's been an amazing journey, which started more than a year ago, and with my family and I moving here. And I just arrived here on Monday, and it's Friday today. But it's been so nice experience being here with all the transition happening. Once again, thank you all so much for having me here. So this talk that I'm presenting today is mainly work done at my previous workplace, LB Prasad Institute, where I worked for almost 20 years. This is about the RPE transplant, which is suspension of RPE cells for dry macular degeneration patients with geographic atrophy. And upfront, I would like to acknowledge the team at iStem, which is the company which owns this product of RPE stem cells based out of Bangalore, good friends of mine. And also the GMP facility at LB Prasad Institute, where these cells are manufactured. The Image Reading Center at LB Prasad Institute, Data Safety Monitoring Board, who were monitoring the data very closely, and also Vas Sada from Doheny, who is the chair of the board, advisory board for us. So macular degeneration is very common, very highly prevalent, more so in the West. There are more than 10 million patients affected with dry macular degeneration in the United States, and the prevalence in the population above the age of 40 is about 2%, about 60 is about 24% in the West, based on the Wisconsin epidemiologic study. But in India, slightly less prevalent. I would say if we were to see a patient here above the age of 60, and we see 5 or 10 drusen, over there you may find 1 drusen. The ratio of 1 to 5 probably. We don't know why. But yes, it's still common in India, and based on the data of LV Prasad Institute of over 6 million patients, we had about 1.68% of patients over the age of 60 dry macular degeneration. We also had the APET study, which was the Andhra Pradesh eye disease study, where the prevalence was about 1.2% in patients or population above the age of 40. So what's the problem if you have geographic atrophy? You can be legally blind with the vision so far, whatever treatments that we have, they can help reduce the progression of these lesions. But typically, this is a relentless condition where the photoreceptors are lost primarily because the RP and choriocapillaris, they atrophy. And we all know that choriocapillaris provides nutrition to the photoreceptor. So if the choriocapillaris is having less blood supply, the RPE, the photoreceptors and the RPE are also getting less nutrition, and they undergo atrophy. And that's where the challenge is that the RPE and the photoreceptors do not regenerate. So it's difficult to reverse this disease by conventional treatment. But it's a slow progressive disease. So unlike wet AMD, where you can design clinical trials and show results at 1 year that one drug was better than the other. Whereas in a slow progressive disease, it could be any disease, but if you are a clinical trial specialist to design a clinical trial where the natural history is slow progression, the treatment, the new treatment which you want to compare, you need a couple of years or 3-4 years before you have a clinically significant result. But that's a challenge with dry macular degeneration as well. So this is of a patient with dry macular degeneration. As you see, yeah, drusen, they're there, but not that many, but very advanced geographic atrophy. And on the OCT, you can see that there is loss of RPE, or at least attenuation of that. Choriocapillaris is certainly thinned out. It's a very, very thin line. It's just the dark line under the RPE is the choriocapillaris. And as you can see in the area of atrophy, you don't see that hypo-reflective dark line under the RPE, which means the choriocapillaris is lost. So if you want to prevent macular degeneration, I think one must be looking to keep the choriocapillaris blood flow intact. If the blood flow of the choriocapillaris is intact, probably the photoreceptors and RP are also not going to degenerate. But if patients already have this geographic atrophy and loss of photoreceptors, it's a challenge. The current treatments, mainly neuroprotective agents, steroids formulations, and even the newer injections of complement inhibitors, they reduce the progression. They do not reverse the disease. And that's where in patients with geographic atrophy who already have lost their vision, they cannot get back or regain their vision. And that's where this treatment of stem cell therapy is being looked up to. These are initial phase study results. So we still have to wait for some time before we are sure what we are achieving. The current treatments of complement inhibitors, we have avacincaptad, which is a C5 inhibitor, complement 5 inhibitor, which is lower down the cascade of the complement pathway. That provided significant reduction in the progression of the lesion. It did not reverse the lesion size, but it certainly helped in reducing the progression of the lesion of geographic atrophy compared to sham by about 27%. And a higher percentage of these patients tend to develop macular degeneration if you were to suppress the complement cascade. Again, just to remind everyone here that the process of macular neovascularization is considered to be body's way of reacting to the hypoxia, which I mentioned. The choriocapillaris, if it gets atrophic, there's less oxygen supply, and the body tends to develop these new vessels so as to compensate for this hypoxia. So some amount of macular neovascularization probably is beneficial, but we don't know at this point of time. We are unable to titrate how much of neovascularization should be left behind when you're treating wet AMD. But inhibiting the complement cascade by these drugs increases macular neovascularization or the risk of macular neovascularization in these patients. And the same was seen with the other drugs, Syfovre, pegcetacoplan, which is a C3 inhibitor, slightly higher up the cascade of complement pathway. But again, MNV, or macular neovascularization, was associated with this as well. So now looking at the stem cell treatment, which we were looking at LV Prasad Institute, we got the regulatory approval for this trial last year, and we have 3 sites currently. One is LV Prasad Institute, the other is the All India Institute of Medical Sciences, which is again a premier hospital in New Delhi, and then Ganpati Netralaya and Jalna. So these 3 sites had the task of recruiting 9 patients in this phase 1 study, which was mainly a safety and tolerability study, trying to look at side effect profiles. We know from the earlier stem cell clinical trials that there could be some amount of inflammation, epiretinal membrane formation, as well as a possibility of these cells probably undergoing atrophy or dying off because they are allogenic cells. So patients have to be on an immunosuppressant regime for a few months. So the safety was the most important outcome that we were looking at. Patients were recruited in cohorts for different doses, 100,000 dose per injection. The first cohort, 3 patients, and then 200, and then escalated to 300,000 per dose. So we completed all the 3 cohorts of 3 patients each, and now we are looking to start phase 2 in probably July of this year. This slide shows us the inclusion criteria. Now, there are 2 reasons why I'm showing. One is the factual reason, but there's another reason why I'm showing this, is that typically inclusion-exclusion criteria run into multiple pages in any clinical trial. That can be a problem for post-approval indications and the differences between a clinical trial result versus a real-world result. So we need to be careful about who all are we excluding in a clinical trial, because you tend to cherry pick in a clinical trial, but if you have too many inclusion and exclusions, you may not be able to replicate your results in the real world. But these patients, in the phase 1 study, we had patients who had less than 2200 vision, because this was the first in human that we were doing. We didn't want to have patients with good vision. But in phase 2, we'll have patients with slightly better vision also being eligible for the study. And the patient's total geographic atrophy area must be more than 1.25 millimeters square, but less than 17.5, not touching the temporal margin of the optic disc. And at least one of the lesions had to be subfoveal. these are the other exclusion criteria. And as I mentioned, it's a long list of exclusion criteria. And this was a meeting that I had with the US FDA director in India on a panel about patient-centric approach. How do we design better clinical trials? And one of the points that was discussed was having kind of criteria which are more replicable in the real world, and you don't get discrepancy between clinical trial result and the real world. And we all know a lot of drugs may be working in a clinical trial setting, but may not be having the same efficacy in a real world setting. Up front, I would just like to show the result here. The average visual acuity gain in this RP stem cell study phase 1 was 14.2 letters. This is for sure a reversal of the disease. So far for dry macular degeneration, we have been trying to stop the disease from damaging or reducing the visual acuity over time. But this one is getting back or giving back, regaining the visual acuity to our patients. 14.2 letters is like almost 3 lines, which is halving of the visual angle. It's considered a big hallmark in visual acuity outcome clinical trials. So this was the phase 1, cohort 100,000 dose. This is important to see whether there was a dose response with increasing doses of stem cell. Was there a better visual acuity or safety concern? So this is the cohort 1 of 100,000 cells. Patients had 10 letter, 30 letters, and 11 letters improvement. This patient 2 was operated by me. The patient actually had a 40 letter, 8 line improvement in vision, which was very unexpected. But we need to enroll more patients and see how many patients actually improve by so much. But this patient again had a drop of 2 lines over the next couple of months. But now he's stable for the last 6 months with a 30 letter gain in vision. With the 200K dose, again, we had 20 letter improvement, 17. Again, these are huge gains in vision, never seen earlier in any trial of dry macular degeneration. And the third patient had only a 7 letter improvement, but that's still quite acceptable. And this is the 300,000 dose where as you can see, it's 12 letters, 2 and 3 letters. I don't see a dose response here at this point of time, but certainly there is a response which is happening. So this is the patient that I would like to present in more detail, which I had operated earlier and had an 8 line gain in vision. As you can see, geographic atrophy, he's about 70 years old, RP and photoreceptor thinning and choriocapillaire is lost. And we use the Retina AI platform, which has AI-based software for calculating the various segmentation of the OCT. And all the reading center as well as investigators sit together for each and every patient to decide whether the patient should be eligible, enrolled, and then look at the site of injection for these patients. So generally, we have to inject at least 2 sites in the retina near the area of geographic atrophy. We don't inject within the area of the geographic atrophy. And in this patient, we had selected 3 sites, one supranasal, infranasal, as well as one infratemporal. So this is the surgery. Yeah, just a standard 25 gauge pars plana vitrectomy. Once the vitrectomy is done, we then the RP suspension is actually brought in about half an hour before the patient surgery started. There's some thawing process, and once the RP stem cells come to room temperature, and that's when we are ready to inject these cells under the retina. So this pars plana vitrectomy is quite standard. You induce you separate the posterior highlight from the macula and the disc. And this cannula, which you can see here, is a 39 gauge, pretty long cannula. And this is an automated foot pedal controlled injection. And you saw that lever was raised over there. And you may get, if you push very hard, the subretinal injection, sometimes you can have a macular hole because the fluid can pass from under the retina and the fovea is quite thin. So it can just open up the fovea and create a macular hole. So it has to be a very, very slow, gentle injection process. And this is the post-operative pictures from Retina AI. And this showed that there were areas of improvement in RPE as well as the ellipsoid zone. And this is the AI generated image, 5.5 or close to 6 months follow-up. There was a reduction in the RPE defect area. And this is what I was alluding to earlier, that on the left-hand side, you see the injected eye, and the other graph on the orange one is the control eye of the same patient, the uninjected eye. So in the injected eye, the RP defect area actually decreased. So far, whatever drugs we have, Izervay, Syfovre, the lesions would still progress over time, even with injections. Whereas here, with the RP stem cell, the lesion size actually reduced, which means it's a reversal of disease. The fellow eye, which is the untreated eye, there is still an increase of progression of the lesion size. This is the photoreceptor defect area. There was again an 8% reduction in the photoreceptor defect area compared to a 6% increase in the untreated fellow eye. And this is the visual acuity chart. At every visit, the maximum improvement was 41 letter gain. Again, I think it's more of an exception. This slide is from the study done by the Wills Eye Institute. Dr. Alan Ho had presented this at ARVO a couple of years ago. They also found improvement in vision, but they have both intravitreal as well as subretinal injections. And it's something which we are looking up to in the future with more and more patients being recruited and see how much replicable this is. But there are challenges in recruitment, at least in initial phase. The criteria are very strict. Patients are on immunosuppression, which is a challenge. Subretinal injection surgery is quite complex. Intravitreal injections, office procedures, you can do 25, 50 a day. Subretinal injections, not so much. And we have a huge burden of patients. So this is going to be a challenge for our patients. And then the durability over a year to 5 to 10 years, what's going to be the visual acuity profile? Is this going to come back? Is the vision going to drop again? Do we have to re-inject these subretinal injections? Something we need to look at in the future. So in summary, there were no adverse events or serious adverse events in these patients, which we saw. Not even a macular hole in these 9 patients. Functional improvement has been remarkable, quite unexpected. Structural changes in OCT are also correlating with the visual improvement. There has been a demonstrable decrease in RP and photoreceptor lesion size, which is now an accepted US FDA endpoint, not just visual acuity, and there is a significant improvement in quality of life of these patients. I would like to thank my team over here. And once again, thank you for the opportunity. Thank you.
I'm sure there'll be a lot of questions and discussion in our moderated session after this next talk. I'm very pleased to have another guest here with us today, our main chief guest, Dr. Rajendra Apte. It's my great pleasure to introduce him to you all. Dr. Rajendra Apte is our third presentation for a session, and he's going to speak on correlating OCT and FA with MRI imaging in RVCL-S through a clinical trial, which brings our topic of genetics into the mix. Dr. Apte is a distinguished clinician, scientist, and a leader in retina. You will hear more about his fantastic work in this afternoon's Snell Memorial Lecture introduction by Dr. Di Loreto. Dr. Apte is highly respected surgeon in vitreoretinal surgery at the WashU Barnes Eye Institute, and he is combining cutting-edge science with compassionate patient care through clinical research. This morning, we're going to hear from him as he shares his insights from his pioneering work in imaging science that relates to the genetic of RVCL-S. I welcome Dr. Apte to come and give his presentation. Thank you.
Good morning, everyone, and thank you, David, and all the faculty for inviting me. It's great to be here. It's always a hard act to follow Dr. Narayanan, but I'll try my best. So for this short talk, I picked a really rare disease that only maybe some of you may have seen. It's called, these may be somehow on timer, so if you can somehow turn it off, that'll be great. The study was funded by the Clayco Foundation, and I'll present sort of very little about the phase 2 eye results, but just leave you with some of the work we're now doing, trying to correlate the eye findings with the brain findings. So RVCL, or as you saw, retinal vasculopathy with cerebral leukoencephalopathy, S, which is for systemic manifestation. So that's the name of the disease. It's an autosomal dominant, universally fatal condition, and there's only less than 200 families around the world. There's a cluster in North America, in Amsterdam, and in Australia. And it's a vascular occlusive disease, and it's not inflammatory. It just causes vascular dropouts in the retina, in the brain, and throughout your body. And it essentially leads to sort of thrombotic occlusion of blood vessels. And you can imagine when it happens systemically, it can cause all kinds of problems, including blindness, strokes, et cetera. As I said, it's universally fatal. Patients start getting symptoms in their early 30s usually, and the median time to death is somewhere in the late 50s. It's from a mutation in a gene called TREX1. I happen to get involved in this because we have a RVCL center at WashU, and so I started seeing a number of these patients. And so the first thing we did initially, and this is published, is just wanted to characterize the retinal vascular findings in these patients. And the reason that's important is it looks similar to a vein occlusion or diabetic retinopathy. And it's unfortunate because if you take a good history, a lot of times because it's autosomal dominant, there's a strong family history. But there's many cases where these patients are treated for as diabetics, or there's a huge workup done to find out if this is secondary to hypertension or something else. So I think the important thing is where if you just if you happen to see a patient who doesn't have a known diagnosis of RVCL, but the clinical presentation it's a little unusual with occlusive vasculopathy, then you might want to suspect that. The other thing is the eye presentations are actually quite variable because you can have a massive capillary non-perfusion but may not get neovascularization. Then there's others that sort of develop very severe disease with neovascular glaucoma. So I work very closely with John Atkinson. Essentially, he's a really well-known complement biologist who did some of the original work on C3 and C5 that has led us to now have complement inhibitors in AMD. And he actually did a very early trial with aclarubicin in RVCL-S that had 4 patients and showed some interesting findings. But this disease is very hard to do clinical trials in because it's rare. The patients are really sick, and so it's almost impossible to do randomized trials here where you only have 150 patients around the world. And so we got really interested in this drug crizanlizumab, which has been approved for sickle cell disease. The data around sickle cell disease is modest, but the interesting part was that this drug is a p-selectin antagonist. So it inhibits the interaction between leukocytes and blood vessel walls. So the idea is, can we improve blood flow, or at least have some early signs to show that by improving blood flow, we can make a difference in retinal and brain perfusion. So what we did was we did an intent to treat study, very small numbers. We started with 19 participants that were included here from our cohort. and sort of going through the exclusion criteria. Again, as I said, it's a fatal disease. So 2 participants actually died during the trial. We were left with 11, and we did OCT imaging and fluorescein angiography. And 1 person was allergic to fluorescein. So we had data really only on 10 patients. And you can see the demographics. Now, these studies get complicated because these patients are also receiving, anti-VEGF therapy for neovascularization, laser photocoagulation, glaucoma surgery. But what we wanted to do was to see if we could quantify with wide field fluorescein angiography the amount of non-perfusion over a 2-year period where they received monthly crizanlizumab injections. And so what's showing you here is we created sort of a manual and a semi-automated version of a 5 millimeter and a 10 millimeter circle, so we could do posterior, mid-peripheral, and a far peripheral measure of perfusion using the MIPAF tool on Opto. So this just shows you how we tried to demarcate the perfused and the non-perfused zones. And this is published again, but I'll show you what we found, and not really any conclusions you can make, but it shows you the non-perfusion index on the left, where you're seeing a sort of a mild slope in these 10 participants of non-perfusion slowly increasing, and then potentially some flattening over the second year of the study. And the results between the manual segmentation and the semi-automated tool were very similar for both the year 1 and the year 2. So somewhat encouraging. This just shows you how you could track a patient over a 2-year period using these tools. And the biggest thing we found, which is not surprising, as you can imagine, that the area where you found the most changes were these border zones in the mid-periphery. Because as you can imagine, the posterior pole is largely perfused until very late in the disease. And then the far periphery is almost completely non-perfused. And so when you're looking for, this is really for the future, if you do non-perfusion studies, the mid-periphery is where you were seeing most of these changes between year 1 and year 2, because those were the border zones of perfusion and non-perfusion. Having seen a lot of these patients and now seeing them with OCT angiography also, it's not like diabetes. These patients can have very bizarre presentations in terms of how their non-perfusion is. So we published these initial results last year in just on the eye findings. But what we've been interested in is that during this crizanlizumab trial, these participants also underwent MRI imaging for what was going on with the white matter disease. And so now we know from like a lot of studies going on, right, with the retina as a non-invasive biomarker for brain disease, we were interested in seeing was there something that we could take from what we were seeing in the retina and what we were seeing in the brain. So I told you about the non-perfusion in the retina. We also had OCTs done on these participants, and then we had flare imaging. And you can see this angiogram is on the same patient. The OCT is not from the same patient, where you can see on the flare on the MRI, the white matter lesions. And you can see over the time going from left to right that there's progression of these white matter lesions. So the way the types of lesions these patients get, it's called the cerebral small vessel disease. And so you have white matter hyperintensity, which goes up with time. You have mean diffusivity, which goes up with time. And then the total white matter volume goes down. And so we were interested in seeing if the eye imaging, which is, of course, is at least the OCT is non-invasive, we could find some correlates over there. And it's very difficult, as you can imagine, because quantifying white matter lesions in the brain is not easy. But we worked with the neurology group, and I'm just going to show you what we found. If you just look at the 3 things in the brain I mentioned and correlate that with the non-perfusion index in this cohort of 9 participants, there's so much variability that there's no statistical significance. But I'll tell you some interesting things that we found on OCT with total macular volume and relationship with what we found on the brain lesion. And we're still working on this. The statistics is also complicated, but we were fortunate to have May Gordon help us with that. So if you looked at total macular volume, you can see on the left that there seems to be a direct relationship. As you can imagine, with neurodegeneration in the retina, a relationship with normalized white matter volume. So as disease progresses, not necessarily surprising that there's a relationship with brain atrophy and atrophy in the retina. Some of the other relationship, diffusivity is is sort of borderline. We had one participant that was completely in an outlier. So when we removed that, it seems that there was an inverse correlation there. But on the right, again, if you just look at this spread of this small group of patients, again, if you look at the total change in macular volume, which as you can imagine, because of the non-perfusion and atrophy goes down with time, you can also see that there seems to be some interesting relationship with the mean diffusivity that we see in the brain. We're still trying to put this together. So there's two manuscripts that hopefully, this will be published in. One is just characterizing the brain findings over 2 years like we did on the eye. And the second one is sort of trying to put this together in terms of can the eye and the retina be used as a biomarker for what's going on in the brain? Because in these difficult rare diseases, unlike AMD, where we can really design nice randomized clinical trials, can we use surrogate markers to find outcomes that are therapeutically meaningful? Because in these patients, of course, we want to prevent blindness, but also we're talking about increasing lifespan. So could there be biomarkers in the retina that are identifiable that can help us evaluate therapeutic efficacy over a reasonable time span? So just in terms of preliminary conclusions, which really are just findings that we have for further discovery, is that on this P-selectin antagonist, crizanlizumab, the rate of progression in this small cohort seemed to plateau over the second year. This requires obviously further study. Although we can't have large numbers, it's going to be small numbers of patients. Like other retinal vascular diseases, the non-perfusion starts in the periphery and then progresses towards the posterior pole, although it's a lot less predictable in RVCL, unlike something like diabetic retinopathy. And the mid-periphery is a good proxy for rate of non-perfusion for the retina, but maybe even in the brain. We need to explore more about crizanlizumab, whether it really does have therapeutic efficacy in RVCL-S, but in other monogenic microvasculopathies, there's other small vessel brain white matter diseases. And so we are exploring that with Andrea Ford. And then in terms of like the eye and the brain, a total macular volume, which is easy to get on our OCT imaging, we have to explore this further, whether this is a promising biomarker to quantify cerebral small vessel disease, at least in RVCL-S, but maybe some other white matter diseases of the brain. So again, I'm no expert in some of the things that I talked about, but I've worked with this incredible team, 2 medical students, Wilson Wang on the left, and then Hennock, who are helped with both the eye and the brain studies. Andrea Ford, who's a neurologist and a world expert in brain small vessel disease, John Atkinson, who I told you about, and 2 collaborators, Dr. Ree and Dr. Miner at Penn. And so we hope to continue doing some of these things, studies through these multi-collaborative efforts, which are very difficult to do in rare diseases. So I think the only point I'll leave you with is for these types of conditions, it's really important to have sort of experts from various different areas, because it's going to be impossible to design large mass clinical trials in these rare diseases. So thank you again for the invitation, and of course, happy to have any questions.
So I invite both Dr. Apte and Dr. Narayanan to come down and be part of a moderated panel here. And if we can get some help with the mics. Any questions in the audience?
I'll start. Raja, thanks for coming and presenting that at work today. It's great. So as we look further into the future for retinal stem cell transplantation, both RPE and neural retinal stem cell transplantation, what do you think are going to be the best clinical objective tests for vision in these patients? And then my second question is, do you think the length of time immunosuppression had to do with the decrease in acuity over time in those RPE transplant patients?
Yeah, great questions, Dev. This clinical endpoints has been a big debate among clinicians as well as with the US FDA. I think, as I mentioned, for a slow progressive disease, if the new treatment slows down the progression compared to no treatment, you would like to look at endpoints like geographic atrophy, lesion size growth, based on OCT or autofluorescence. They are perfectly valid endpoints if you don't get some dramatic improvement in visual acuity, at least you slow down the loss of visual acuity. But in such a situation, I would certainly consider the endpoints of lesion size based on OCT or autofluorescence. But if you have a treatment like stem cell, which can reverse the disease and improves visual acuity, I think then the endpoints should no longer be the rate of progression of the anatomical outcomes. You should again start looking at visual outcomes. And it's we don't want to stop treatments which are good, but if you have a treatment which improves visual acuity, then you take that as the final outcome. But again, the challenges are it's a surgery, it's a subretinal surgery. So I would say it's an evolving situation. So probably we will have to wait and watch. But what was the second question there?
Oh, when you mentioned from that one patient that had the 30 gain line, a 30 letter gain that tailed off after the 6-month period, and I think you said you immunosuppressed him for 6 months. Do you think that was correlated?
Yeah, that's a brilliant question. So what Dave is asking is, if you stop immunosuppression, do the cells start dying? And do you have to keep them on lifelong immunosuppression if they start dying after stopping immunosuppression? So this patient had weight loss 1 month after surgery, loss of appetite, and he was finding it difficult to even walk, not because of his eyes, because of his weakness. And I decided that I have to stop his immunosuppression. I won't go to the physician for the internal medicine folks to check on him. But then he improved after that in terms of his physical strength. And a couple of months after his 40 letter gain, his vision came down to 30 letter gain. But even though his immunosuppression is no longer being given, his vision has been maintained with that 30 letter gain for the last 9 months or so now. So that's something we still have to continue evaluating, monitoring. But all patients had immunosuppression only for 3 months. So we still have to see after the 3rd month, has there been a drop in all these patients? That analysis still has yet to happen with these sponsors. They have to look at the data. But good question, Dave.
Thank you.
Raja, great talk and welcome to Rochester. So was there any correlation between site of injection, the amount of geographic atrophy area and vision? Because every patient responded differently. So if your inclusion criteria was strict in the measurement of the geographic area, and even with dose escalation, there was very variable response. So how do you,
So your question was, with the site of injection, was there any difference in terms of the progression among patients, different patients? So that's something which we still have to analyze. This was the global indices are the RP defect and photoreceptor defects that have been calculated by the automated software. Frankly speaking, WASP has always been on the board looking at these images, and all the investigators. I looked at my patients' OCT autofluorescence very carefully. Do I see any difference pre and post injection? Frankly, I didn't see anything specific in terms of hyperautofluorescence. But the ellipsoid zone and RP definitely had some changes. But on autofluorescence, we didn't find any difference. But I think with more patients, we may be able to get some meaningful data.
Questions?
I'll keep going.
Go ahead.
Raj, so you're using non-perfusion index really as a biomarker for this disease. And I was thinking, have you guys, here in Rochester, obviously with adaptive optics imaging, and we think, the smaller you can go, the better more sensitive it might be. So looking at like blood flow in the vasculature or anything like that, maybe you could adapt that from the OCTA, or I mean, have you been able to look at other factors, just the non-perfusion, to correlate disease severity and progression?
So you definitely could. I think the challenge with, at least with RVCL-S is, I mean, sometimes these OCTAs look scary on these patients. Like you look at it and there's no vessels. I mean, literally there's no vessels. And it's not predictive of vision. You know, you see these massively non-perfused maculas and the patient would be 20/40. And so with adaptive optics, I think the great thing would be you could look at flow and maybe there's some correlates. We just, I mean, don't have the expertise where we are, but something that can be looked at, sure.
You're talking about multi-institutional collaboration.
Yeah, exactly. You know, I had a comment on Dr. Narayanan's talk. I mean, it's interesting, right? This, the scalability is a challenge, of course, with AMD subretinal therapies. But the other question I had for you was, do you think when they do the iPS-derived RPE, right? So these are not autologous. And do they screen for the polymorphism? So, I mean, I wonder if you pick RPE that has a, you know, CFH mutation, is it going to survive less than some like a healthy iPS RPE that does not have at least the known AMD genetic issue?
Yeah, that's a very important question, I would say. I don't think I have the answer to your question, but I can ask scientists who have done this. But these are from one patient that we have about 80 million cells right now. So it's like you can treat almost the entire population with these cells right now, what we have. Seems to be working, but we should probably be looking at this in the future.
I actually have one question for Dr. Apte. So now that we're seeing that the eye is becoming the center for imaging the vasculature and understanding systemic disease as well, and it's coming out of the realm of just eye doctors, ophthalmologists, and optometrists who have access to these images now with this imaging technology that we have. What is the role of ophthalmologists in working with people in cardiology and in psychiatry, neurology, and other areas where they're using the eye as a biomarker in interpreting these images? Because we have the Center for Retina and Brain here, and I find there's some spurious correlations that non-eye people can make. So I'm just wondering, what is the role of ophthalmology now in this new burgeoning field of oculomics?
I think that's a really good question because there's mountains of, you know, literature now on every kind of correlation you can imagine. And my bias, including what I just presented, is that until you do sort of unbiased large studies, many of these correlations are probably not real. And so whether it's through, you know, machine learning, AI approaches, et cetera, we sort of need to really define, you know, associations that are truly real or meaningful, especially if you're going to use them as biomarkers of disease or progression or therapeutic response, as opposed to just sort of, you know, random associations, you know, that just happen by chance. And so I think it's going to be sort of large teams that use sophisticated imaging and and until we get there, I think, you know, at least I don't think our jobs are at risk.
Any other questions from the audience?
Do you mind if I ask you a question since Amade's done here? I know there are a number of infectious diseases on the rise in our region, in the country in upstate New York, and you presented some great cases on syphilis on our other rounds the other day. Is HIV upticking now, or are we just seeing more CMV retinitis here because we have two great uveitis specialists?
I don't know about HIV in general. You know, I certainly also see my fair share of very well-controlled HIV patients with no ocular disease. I think CMV is just rare, and usually maybe if people aren't recognizing it, it sort of ends up at a tertiary or quaternary center.
My second question was, can you just go from intravitreal foscarnet straight to oral valganciclovir for treatment, or do you have to do IV?
You can go straight to oral.
Straight to oral.
Yeah, because CMV retinitis progresses so slowly that you have time. And so if there's no other reason for them to receive IV therapy, if they don't have CMV viremia or any other systemic symptoms, if it's just ocular disease, I will treat them outpatient as well.
Great. Well, thank you for this session.